For those of you who don't know me, I'm James. I'm one of the EMIM5s. Thank you to Drs. D'Souza, Lammert, the CCM team. And this is basics of mechanical ventilation. So some disclaimers. I'm not a pulmonologist. I'm not an intensivist. I will be in 3 years. You're not going to learn all of mechanical ventilation in a 45, 50-minute lecture. And this is sort of generally for the interns, the case for everything, right? You're not going to learn anything from lectures. You've got to go and put in the work. These are general concepts. Individual patients in real life, they don't fall neatly into boxes. Medicine is sometimes more of an art than a science. This is one of those topics you really, really have to go out and try to do more. Ask your attendings. When you go onto your MICU rotations, your SICU rotations, ask a lot of questions, watch a lot of lectures, and try to apply a lot of this to the bedside. I thought this was really interesting. So I looked back at the 2024-2025 conference schedule, and I looked to see if we had any lectures on mechanical ventilation. We had maybe 0.5. Anna mentioned it briefly in her lecture, and Ari mentioned it briefly in his lecture. And it's funny, in 2015, they did this study. I don't know why one would do this study, but they did it. And how many hours of lecture on mechanical ventilation in the last year? Do you see how little people had in an emergency medicine residency? How many people do we intubate in CCT every day? We intubate a lot of people. So I think this is important. So let's start with a series of 2 respiratory cases. And this is your visual prompt. Not looking very good. 45-year-old man, history of HIV, coming in with fever, cough, and dyspnea, febrile, tachy, tachypnic to the 30s, setting 70% on 15 liters non-mer breather, weighs 70 kgs, and thin, sitting upright, unable to speak full sentences, but protecting his airway. You trial the patient on non-invasive without success, and the patient remains hypoxemic. Chest x-rays full of fluffy bilateral infiltrates, and you intubate this patient with acute hypoxic respiratory failure. And then your respiratory therapist comes and asks you, what ventilator settings do you want to put this patient on? Think about it. Here's your second visual prompt. 30-year-old woman, history of severe asthma, previous VV ECMO, multiple ICU admissions, coming in for 2 hours of respiratory distress. The patient sustained respiratory arrest en route and was intubated by EMS. Perfusion remained intact. Currently being bagged, hypertensive, tachy to 150, being bagged at a rate of 20 by EMS, setting 94%. She's given all the stuff, right? We just talked about it. And she's even on an epi drip, sedated with ketamine. And then your respiratory therapist asks you, okay, doc, what ventilator settings do you want to put this patient on? Hope these 2 cases gave you a little bit of nervous energy. It would make me very nervous too. Hopefully the attendings as well. So this is not a lecture on why we intubate, but I kind of have to touch on this because we're talking about after the patient gets the tube stuck in their throat, right? So why do we intubate? Airway compromise is 1. Type 1, hypoxic respiratory failure. Type 2, hypercapnic respiratory failure. Type 3, mixed. And the expected clinical course. That one's a little bit funny. If your patient has pneumonia and they're requiring mechanical ventilation or they're just requiring a ton of support and they're super, super tachypnic, the pneumonia is not going to be resolved in the next hour or 2. The pneumonia takes days, weeks even, sometimes to resolve. So if your patient has a lobar pneumonia, it's knocked out the right side, essentially, and they're having a crazy amount of worker breathing, you may want to intubate them to support them because you know what their hospital course is going to be, right? They're not going to do well on the floors. And so does it matter to know how to set the settings on a vent in the emergency department? Well, this study tells you that it does. It improved mortality from 34% in the pre-intervention group to know how to set lung protective settings on the ventilator to 20%. So would argue yes. So now that we've talked about why it's important and all that stuff, let's talk about the goals of mechanical ventilation. And before we talk about the goals of mechanical ventilation, I think we should talk briefly about the goals of our respiratory system, right? It's to oxygenate and to clear CO2. And by the way, if you didn't know, CO2 is a major method of acid clearance from the body, arguably more important than the kidneys. Dr. Center. So, and for mechanical ventilation, there's 2 major things, right? So like I just mentioned, we're trying to simulate the role of the respiratory system. And so there's ventilation, which is CO2, and oxygenation, there's O2. two super broad strokes way of talking about it. So for ventilation, it's going to be modulated by tidal volume and respiratory rate, okay? And for oxygenation, it's going to be modulated by FiO2, fraction of inspired oxygen, and PEEP, positive end expiratory pressure. And then just overall for mechanical ventilation, think about the vent as a crutch, right? So if your patient fractures their ankle, you put them on some crutches, or sprains their ankle, put them on some crutches. The crutches aren't fixing the problem. You don't intubate the patient to fix any problems. You're intubating the patient to support their respiratory system, right? So let's talk about ventilation, arguably the more important of the two processes. By the way, your work of breathing and your respiratory drive increases from CO2 elevation more than hypoxemia. The CO2 level in your body is super, super tightly regulated by chemoreceptors in your sort of like your brainstem area. So again, tidal volume and respiratory rate. Tidal volumes, 6 to 8 cc's per kg of ideal body weight. So take a look at this full body X-ray before they got their CAT scans. The person on the left is 200 kgs. The person on the right is 100 kgs. You can't give the 200 kg person, I don't know, 8 times 200, 1600 cc's of air for every single breath. That's a lot of air, right? So the person was born genetically with that size lung. Just because they put on a lot of soft tissue does not mean that their lungs also grew as well. So don't forget, it's ideal body weight. And I keep this little chart in my phone just in case, I want to know their ideal body weight based off of their height and their gender. We can send out the slides. You guys don't have to take pictures of this. And if you just Google it, there will be many little charts that you guys can look at. Or you could calculate it, yes, but I don't like to calculate. So that's tidal volume. And briefly touching on respiratory rate, there's a thing called auto PEEP or breath sacking. There's more to come later for this, but be careful about your respiratory rate and increasing it too much. If your patients have a bronchoconstriction, anyone who's tachypnic to maybe like the 30s, you will automatically breath stack. And so going to the top, let's talk about the idea of minute ventilation. I think when I first learned about minute ventilation, I was like, oh my God, this sounds like such a crazy, hard topic to understand. It's really not. It's just tidal volume times your respiratory rate. And this is a good number to remember. Your normal minute ventilation is 5 to 7 liters per minute. Okay. And that's a good number to remember because that also happens to be sort of around the normal cardiac output as well. So if you want to improve ventilation, you want to reduce the person's PCO2, which is a respiratory acid, you either increase the tidal volume, but you're kind of limited by the 68 cc's per kg, or you increase your respiratory rate, which is why I'm saying be careful in some of these patients that you increase your respiratory rate in. So we just talked very briefly about the goals of ventilation. Let's talk about oxygenation. So again, FiO2 and PEEP modulate oxygenation. Let's talk about the goal PaO2 is around 55 to 80 if you were to get an ABG in the emergency department, which is really tough to do. But it's a good surrogate is SpO2 on your O2 set. It's 88 to 95%. There's this idea of toxygen. I love this term. So oxygen toxicity. So there's a study here. This is actually one of many. If you had a low PaO2 in your hospital stay, it increased hospital mortality. I think that's pretty obvious. If you are mechanically ventilating someone and you are doing whatever you can to improve their oxygenation and they still can't improve their oxygen, I think it makes sense as to why their hospital mortality is high. But if their PaO2 was really, really high on the other end of the spectrum, their hospital mortality also was pretty high. So there was like a U-shaped sort of distribution of hospital mortality. And that introduces the first one of 5 ideas of ventilator-induced lung injury. Oxygen toxicity is one of them. So just as you're using your ventilator to oxygenate and ventilate, you're also trying to prevent harm. If your crutches were harming your sprained ankle, you probably wouldn't want to use those crutches. So just like that, the crutches of the lungs, you don't want to use this if it's harming your patient, right? So there's 5 modes of VILI, right? 5 things that ventilator-induced lung injury. So one is oxygen toxicity. Why? Oxygen is super important for life. Why is oxygen harmful? Well, I'm going to take you back to biochem, right? There's increased free radicals And when there's increased free radicals, it causes damage to the lung parenchyma. And eventually, over time, this causes something called biotrauma. That's number two. Biotrauma is all the way at the end. It's the final common pathway for all of these modalities. Two, so there's barotrauma. You use too much pressure, it induces alveolar rupture, and then you have all the complications that you think about, like pneumothorax. Something called volutrauma. So there's too much volume you give to these patients, you get alveolar distension, and that alveolar distension doesn't pop it, it still causes inflammation, and that inflammation causes biotrauma. Atelectatrauma, so your alveoli are just kind of continually just being compressed and expanded. That causes excessive shearing forces. That also causes inflammation, and that also causes, number five, biotrauma. So there's inflammation from all of this stuff causes increased edema and impaired gas exchange. So you're harming your patient when you want to actually help them. And then let's now move on to physiology, which I think is the foundation of mechanical ventilation. I purposefully didn't mention PEEP because I thought it was more, it fit better in the physiology section. So what is PEEP? What is PEEP? I think in order to talk about PEEP, in order to talk about positive pressure, you kind of have to understand what negative pressure is like. So as every single person here is breathing here, we're all using negative pressure ventilation, right? So what happens? You contract your diaphragm, it flattens, right? You contract a little bit of your intercostal muscles and it expands the rib cage. It expands the intrathoracic cavity. It creates negative pressure, and there's a pressure gradient coming from the outside, and that's why the air actually enters into your body. That's kind of a good theme to remember for especially cards, pulmonary, renal, that when there's a pressure gradient, that's when, right? But positive pressure, we're flipping that on its side and we're actually using the ventilator to push air into the patient, right? So positive end expiratory pressure. So at the end of each tidal breath, whatever pressure is there to help stent open the airways that the ventilator is still giving a little pressure to, that's the pressure, that's called PEEP. So who cares about PEEP? Well, I'll show you why you should care about PEEP. Here's an interesting video. So this is a rat lung, and they intubated this rat lung, and I'll show you, I think video does a lot better than my fumbling over words. So they're giving this rat lung a tidal volume. Hopefully it works. And you see it inflate, and you'll see it without PEEP, it deflates all the way. So another breath. You see all this atelectasis, atelectatrauma, right? So you add in some PEEP and look what happens. Oh, wait, yeah, it's not doing the atelectasis anymore, right? And you see how it takes a few breaths for all the atelectatic alveoli to recruit, right? And eventually it expands all the way. Happy rat lungs, yeah. So one of the biggest benefits of PEEP is alveolar recruitment. If you guys are familiar with the pre-oxy trial, that's probably one of the reasons why the pre-oxy trial was successful, because of alveolar recruitment using PEEP. And then, so when you have, you're recruiting all these alveoli, now they can participate in gas exchange, you'll improve your VQ matching. Oh man, this VQ matching, what is he talking about? All right, so when your alveoli are all compressed, right? Those alveoli are still getting perfused by the pulmonary capillaries. But those pulmonary capillaries aren't participating in a gas exchange because they can't dump their CO2 and they can't pick up any oxygen. So when you expand these alveoli, and now that alveoli is able to participate in gas exchange, you're able to exchange the CO2 and the oxygen, right? So that'll improve what we call shunt physiology, right? V is 0 and Q is 100, shunt physiology. And then lastly, there's this idea of functional residual capacity. So everyone take a breath and then just let go. Don't let go too much. It's at the end of your tidal breathing. So let me ask Kelly a question. Do you think that when you exhale, but don't exhale fully, is there still air left in your lungs? Yes, there is, exactly. So yeah, there's still air left in your lungs after you breathe out. Actually, there's still air left in your lungs even after you force all of the air out that you possibly can, right? But at the end of tidal breathing, when you force some of the air out, you still have air left, which is called the functional residual capacity. So the other thing is, who cares about FRC? Well, I'll tell you why you care about FRC. So let's go back to when you're intubating your patients, right? So when you paralyze your patient, are they breathing? No, they're not breathing. But for some reason, you're panicking. You're like, you have your laryngoscope in the patient, and you're like, oh my God, I need to put this tube in. Oh my God, you're sweating bullets. Your palms are sweaty. And then you look up at the screen and, oh, they're still setting 100%. What's going on? That's crazy. Well, the FRC acts as a reservoir of oxygen, right? So that's why it's important. And actually, there's this idea of closing capacity. In older patients, in patients who are a little bit more obese, in patients who have injured lungs like pneumonia, there's this area. You guys can see my mouse. You see that the closing capacity is where it's the volume at which like a lot of the small airways tend to collapse and it causes atelectasis. You see here, with this person's tidal breathing at a PEEP of 0, you're actually closing off a lot of the alveoli. Just even like yeah, you can see this on the graphic. But when you give them PEEP, you increase their FRC and you prevent them from de-recruiting and causing atelectic trauma. And so that's why PEEP is important. And it can't be a lecture that I give without talking about the heart just a touch. So there's cardiopulmonary interaction and positive pressure. So again, just like when we talked about regular breathing, I think we should talk about what happens in cardiopulmonary interactions with negative pressure ventilation. So don't look at this. Let's pay attention this way. So again, when you're breathing, you increase your intrathoracic cavity. And when you increase your intrathoracic cavity, what happens? You create negative pressure. That creates a little bit of a suctioning effect that not just brings air, that doesn't just bring air from the outside in. The capacitance vessels in your body are the veins, SVC, IVC. It'll dump a little extra blood into the right side circulation, right? So a little extra blood goes into the RA, into the RV, and that improves right-sided cardiac output, right? And if you improve right-sided cardiac output, it dumps extra blood into the LA and therefore the LV, and it improves left-sided cardiac output, right? But if we flip that on its side and do positive pressure ventilation, what happens? We create a lot of resistance to flow that's coming back from the veins. So the SVC and the IVC can't dump as much blood into the RA. So you reduce right-sided preload. You reduce right-sided cardiac output. And if you reduce right-sided cardiac output, you reduce left-sided preload. And if you reduce left-sided preload, you reduce what? Left-sided cardiac output, right? And not only does it reduce left-sided preload and cardiac output, it reduces afterload, LV afterload. It's through a complex mechanism. If you want to talk about it, we can talk about it afterwards, but it reduces transmural pressure and therefore it reduces LV afterload. But on the other hand, for the RV, it increases RV afterload. There's now a ton of pressure that the RV has to press against. And imagine there's this thin frail, remember the RV is the thinner walled version of the LV. If that thin-walled, weak RV is already seeing really, really high pressures, i.e. during massive pulmonary embolism, and you give that extra afterload, right? You give positive pressure, you decide you want to intubate this patient, and you give them extra afterload, that's not good for the RV, right? So that patient's going to crash. On the other hand, in a patient with LV failure, remember, positive pressure reduces preload and reduces afterload, but in the setting of LV failure loves PEEP, right? So that LV is already like it's drowning and it can't do anything. So you take away a little bit of that extra fluid that it's getting every beat by reducing preload, and you reduce the load that it has to press against by reducing afterload. PEEP is very friendly to a failing LV, so don't forget that. It's actually a way you can augment cardiac output without using pressors in LV failure. All right, so talked a lot about this stuff. So let's come back to a more complicated topic. I'm just kidding. Lung compliance is really not that hard to understand. So it's lung stiffness. Just think about it as lung stiffness. And I think now we can pull out our balloons. All right. So everyone pull out. There's a balloon that has the arrow on it. Okay. Take the other balloon and blow it up to the size of, let's say, a big softball. So go ahead. Everyone blow that up. Some people's softballs are bigger than others, but think about how difficult that was to blow it up. Now go to the balloon with the arrow on it and blow it up to the same size. I went on Amazon and I looked up extra thick balloons. So They feel kind of similar because you were playing with it before and you messed it all up. No. All right. So, all right. You guys had fun. The balloon with the arrow on it is thicker. It has decreased compliance. Okay. So it's the propensity of the alveoli or the balloon to want to snap back, right? That's decreased compliance. It's less wanting to do what you want it to do. You have to give it more pressure. So the equation is the change in volume over the change in pressure. uh, in order to achieve the same volume, you'll have to get an increased pressure, and that decreases compliance, right? So in what lung states or in what like actual lifelike states does this happen? Well, it happens in injured lungs, lungs with pneumonia, lungs with edema, obese patients, because they have a ton of like extra outside pressure that prevents you from expanding things, that causes decreased compliance. But also, if you guys actually noticed, when you first tried to blow up this balloon, that's kind of when your volume is sort of down here. All that pressure that you gave it only increased the volume by a little bit of an amount. So that's during states of atelectasis. Your lung actually becomes less compliant when it's atelectatic. Okay. And on the flip side, on the other hand, when your lung is overdistended, imagine this balloon super inflated, and you're trying to force air into this balloon. Eventually it's going to pop, right? But your lungs also become less compliant when you're overdistended. Your lungs happen to be at its happy compliance level when it's, oh, look at that, FRC, when you're at functional residual capacity. That's when it's most compliant. And then, so we talked about compliance, and so we have to talk about resistance. Oh, yeah. Oh, that was complicated. All right. So all of these equations have to be memorized. You think I'm joking? No, I'm not. All right. I am joking. Okay. So the only thing I think that's super important in this equation is this r to the fourth power. This is, I can never say this man's name right. Poisson's law? Poisson, yeah, whatever. His law. So notice Q, flow, is definitely related to radius. I think this is a little bit of an easier picture to show, but even easier is if we used our balloons. So pick the balloon you want to use. I don't care. You want to make it harder on yourself, pick the one with the arrow. If you want to make it easier on yourself, pick the balloon without the arrow. Now, everyone simulate asthma and kind of squeeze the airway a little bit, okay? And try to blow in that same amount of volume into that balloon. It's hard, yeah? So it requires a lot more pressure and flow and force to inflate the balloon when it has increased resistance. All right. That's enough. This is what I was afraid of. I was like, oh, all these guys are a bunch of kids, man. They're just gonna want to play. All right. So, because while I was making this, I had a lot of fun too, honestly. So now you have your patient that's already bronchoconstricted and it already has a lot of resistance. Think twice about using a 6.5 ET tube, right? Try to use larger ET tubes so you don't want to add to the resistance that the patient's already feeling, right? So try to use as big as the patient can tolerate. All right. So we talked a lot about all the, like the foundations of stuff. So let's actually talk a little bit about the ventilator. All right. So this is the Draeger. For those of you that have seen it, it's at downstate. What you want the patient to get is at the bottom. So you want the FiO to be 80%, you want the tidal volume to be 500, you want the respiratory rate to be 12, and you want your PEEP to be 5. That's what you're requesting the ventilator to give. And on the right is what you're actually getting from the patient, right? So the patient's very well synchronized with the ventilator. So they're getting exactly what you're setting the ventilator to give. And here are the waveforms. Always, in every ventilator, you're going to see pressure on the top, flow on the bottom, flow in the middle, and volume on the bottom. It's over a period of time. So as the patient breathes, you'll see this waveform just go back and forth, okay? So notice here on the top left is the actual mode that the ventilator is using. So for us, for our purposes in the emergency department, I think it's not useful to try to remember all the modes. I think it's useful to remember one of the modes and know it really well. And the most common mode is volume control, right? So there's mandatory and assisted modes. Mandatory, we don't really use anymore. Mandatory basically says, you can't do what you want to do. I'm going to tell you what you want to do, and you're only going to get this. So if the patient wants to breathe at 16, the ventilator won't let it. Nowadays, we're not so cruel, and we use volume control, assist control, right? So in VCAC, what actually happens is, so you're going to get 12 breaths per minute, mandatory regardless. But if you decide that you want a breath and the patient just goes, and it triggers a little bit of extra flow or pressure, then the ventilator will go, okay, the patient wants to take an extra breath. We'll give you a fully supported breath. So each breath will look like this if they're synchronous with the vent. And this is just another example of at county, when you're up in MICU or you're up in the SICU, you're going to see the servos. So again, but it's the same thing. It looks more fancy actually, but it's the same thing. What you want to set is at the bottom. What you're getting is on the right. You'll see the waveforms over time, and you'll see the type of ventilation the patient is getting, the mode of ventilation that they're getting. Like I said, let's go over volume control a little bit. So the most basic form of volume control, it's actually governed by, it's actually flow related. So the ventilator is just going to give you a set flow that you set. And if you notice that there's a square waveform on the flow, right? This is inspiration, and below the excess, this is exhalation, right? And so this flow stops when it achieves this target volume, okay? So it'll terminate once it reaches the volume that you set, which is what? 500. So as soon as it gets to 500, the flow stops. And notice how it uses whatever pressure it takes in order to achieve that volume. So it goes, peaks all the way up here. And then once you exhale, it comes back down. And notice how the pressure doesn't come back all the way down to 0. It comes back down to 5. Why? Because that's the positive and expiratory pressure, right? So what is the benefit of volume control? Volume control, the benefit of it is that it guarantees a certain volume and it guarantees a respiratory rate. Oh, right. Volume times respiratory rate is the minute ventilation. So it'll guarantee you a certain minute ventilation. What are the cons? Well, it's not really how we breathe, right? Everyone taking a breath again. You notice that your flow is really high in the beginning and it trails off at the end. We don't breathe like, I don't even know how to simulate this. We don't really breathe this way. So patients sometimes are a little bit less synchronous with the vent because it's uncomfortable. Now, it's beyond the scope of this talk, but there's a lot of other ways that now newer vents have made it more comfortable. There's a decelerating ramp, and there's all this stuff to make it more comfortable for patients. But just so that you guys know, when you're setting patients on volume control at the most basic setting, your patients may be a little uncomfortable and dysynchronous with the vent. All right. So now that we've gone over the simpler waveforms, I want to teach you guys something that's pretty important in terms of how to link physiology in with the ventilator. So there's something called an inspiratory hold. So notice how here, so in most ventilators, there's a button. So as the patient inspires, you hold this button and it stops them from breathing. Unfortunately, the ventilators at county and the emergency department does not have the inspiratory hold button. I like freaked out one day. I was like, RT, come here. Like, let's work with this. Like, how can I not do an inspiratory hold? There's actually on one of the settings, there's like a calculated version of a plateau pressure. But anyways, let's talk about what the plateau pressure really is. So as the patient's breathing in, again, this is volume control, right? Because it's a square flow waveform. They get all of their volume up to 510 cc's. And it takes whatever pressure it takes in order to get all the way up there. And then you press inspiratory hold, and what does it do? It'll just hold that. It's the end inspiratory hold, so it'll hold all of that tidal volume in your patient and stop all the flow. So if you notice here, the flow waveform, it just stops at 0, right? Normally, the patient breathes out and you get this expiratory flow limb. But instead now, you're completely stopping it. That's why the volume stays at 510. You hold it for 1 to 2 seconds to allow the pressures to equilibrate in the lungs. And that end, this plateau pressure, the end inspiratory hold pressure here, plateau, is 31 in this patient. And by doing so, you get rid of all of this flow and resistance. Remember when you guys squeeze down on your tubes, there is some resistance there and it required more pressure to get the air into the alveoli. But once you stop, you're getting rid of all of the airway pressure. And once you get rid of all the airway pressure, you're seeing what the true pressure is in the alveoli. So another word for plateau pressure is alveolar pressure. This is the pressure that matters for barotrauma, not the peak inspiratory pressure, because this all has all the stuff that the air turbulating through the airways and stuff, right? But this is the pressure that your alveoli really care about. And the number is less than 30. Okay. This is actually a marker of compliance, right? So if there's a volume, there must be a pressure. You give it 500, this lung, this set of lungs, you give it 510 cc's, and it gave you a pressure of 31. How do you decrease the plateau pressure? Well, you just give it a little less volume, right? It takes more force to, if you want to, you can try it. You can blow air into the balloon and hold it there. It requires a certain pressure from you to keep that air inflated, right? So, and if you put in more, then it's going to be harder for you to keep that in. You see all the air rushing back at you, right? So it takes more pressure. And okay, so why do we care as emergency doctors about the inspiratory hold? Well, because it's the most accurate right after the patient's intubated when they're still paralyzed. And it's important for you to know, because let's say you think you're setting 6 to 8 cc's per kg, you think you're doing all the right things, and then now their plateau pressure is 40. So until the ICU comes down and evaluates your patient, until they fiddle with their vent, do what they do, we're harming our patients if we leave their plateau pressure at 40, right? So you're causing what? Barotrauma this time. So just to recap again, you start here, you inspire, you reach a peak pressure, and you hold it, and you create a plateau pressure, or the alveolar pressure. And all of this pressure between the peak pressure and the plateau pressure is the resistive pressure, okay? Like I said, optimizing plateau pressure, you decrease the tidal volume. Right after intubation, you're probably not trying to decrease PEEP, but for those that are going to end up rotating in the MICU, if you give way too much PEEP, remember, if there's a pressure, there must be a volume. Your PEEP can sometimes, we set PEEPs at like 18, 20, and that actually may cause your alveoli to overdistend, and that can also increase your plateau pressure. And in the setting of asthmatics, that's when it's important in the emergency department. When they're auto PEEPing, they already have a lot of volume still left in their lungs at end exhalation. That causes a pressure. And we call it auto PEEP because that's intrinsic PEEP that the patient is getting for themselves and not something that the ventilator is giving us. That can also cause distension and cause your compliance to be poor and cause your plateau pressure to be high. We're going to go over that again later. All right, so it's a lot. So let's go now talk about the cases that we talked about in the beginning, okay? This is, remember, our HIV patient that was uncontrolled with hypoxic respiratory failure. You intubated this patient, and recall the CT scan of this patient, right? So remember, there's all of this junk in these lungs, right? What do you think is going to happen if you set 6 to 8 cc's per kg? Do you think the volume is going to want to go to these atelectatic, filled with pus? Like the volume is not going to go there. Actually, it's pretty interesting. Put both balloons in your mouth and blow in a softball's worth of amount. See where the volume goes. Isn't that weird? Isn't that weird? The resistance is the same. The airway size is the same, but for some reason it goes into the part that's that's more compliant, right? And to the place where it's easier for it to go. So if you give this lung 6 to 8 cc's per kg, you're actually going to overinflate the good lung. That's a problem. So that's my nephew, actually. I don't have a kid, but that's my nephew. So it's something called baby lung phenomenon. Just like you go, and you want to protect this baby, protect your patient's baby lungs too, okay? All right. So this is the classic ARMA trial, the ARDS-NET protocol. They, believe it or not, back in the day, I guess before I was in medicine, all of us were in medicine, they used to give like 12 to 15 cc's per kg, right? And this is before they knew. This is the landmark trial that compared 6 cc's per kg to 12 cc's per kg, and it showed that there was an actual mortality benefit. This same group actually did a follow-up study to see if there was a benefit between lower and higher PEEP as well. So in terms of ventilation, remember, it's lower volumes, 4 to 6 cc's per kg. There's going to be a summer slide later. But in terms of oxygenation, they came up with these PEEP tables. And actually, the worse the ARDS, the worse the lung injury, the better it is to use higher PEEPs. But let's be realistic in the emergency department. Are you really going to sit there every 15 minutes and go to your patient and titrate the PEEP and titrate this and check a plateau pressure every 15 minutes, all that stuff? You're not really going to do that in an emergency department. But I think it's important for all of us to know that it's not just FiO2, right? Oh man, the patient's oxygen is 85, bump the FiO2. That's not the solution. Why? Remember, oxygen toxicity. This is maybe the third time I've talked about this now. If you get the reactive oxygenation species, the free radicals will damage all the good lung, and eventually, when they're in the ICU, it'll be impossible to oxygenate these patients. So remember, PEEP set a little bit higher than you think. As long as the plateau pressure is okay, as long as their hemodynamics are okay, there's a lot of other things, right? I'm not trying to teach you all of mechanical ventilation here. There's things called driving pressure that you can look at the pressure volume loops as well. There's a lot of things, but just try to remember PEEP and not just FiO2 when you're oxygenating your patients. Look at this. They went all the way, even before they reached a FiO2 of 100%, look at the PEEPs, like they're 20, 22, even on the low PEEP table, right? Before they reached 90% FiO2, I see FiO2s of 100% all the time. We just leave them there, and that's a problem. So think about using PEEP as a way. Honestly, if there's any recruitable alveoli, this should be done within your shift. Within 30 minutes to an hour, you'll be able to recruit the lungs that are able to be recruited. You're not going to be able to recruit all of the pus-filled lungs, the lungs with pneumonia. That takes a lot of time. But if there are lung units that are able to be recruited, you can recruit them. All right. So in summary, lung protective ventilation and severe lung injury, for example, ARDS or severe multifocal pneumonia. In terms of ventilation, 4 to 6 cc's per kg. And again, because of the baby lung phenomenon, right? And there's this idea of permissive hypercapnia. Remember, minute ventilation, you're using tidal volume and respiratory rate to try to get rid of their PCO2. But if you can't, remember PCO2 is not a little bit, it is a respiratory acid. And if you build up your PCO2, your pH will drop eventually. There's this idea of permissive hypercapnia where you allow and you're okay with the PCO2 being at that level if you're able to at least maintain a pH above 7.2. But if you really can't and you really have to blow off more CO2, preferably increase the respiratory rate over their tidal volume. Okay. In terms of oxygenation, your goal SpO2, I put SpO2 because that's realistic in what we can do in the emergency department, 88 to 95%. And remember to focus on PEEP. Prevent harm by monitoring the plateau pressure to prevent barotrauma, and that number is less than 30. Okay, so back to our inspiratory hold maneuver. Remember, all of this pressure between the peak pressure and the plateau pressure is governed by resistance. And where is resistance important? In our asthmatic patient, right? So our severe asthmatic that we had to intubate in respiratory therapy, or the EMS is bagging at 20 breaths per minute. So in your asthmatic patients, if you were to do an inspiratory hold, you're going to see, well, before you even do the inspiratory hold, every time you give it a breath, you're going to see crazy high peak pressures. You're going to see pressures of like 50, 60, to the point where you may even have to like raise the alarm on the ventilator in order for the ventilator to be okay giving that much pressure. But once you do an inspiratory hold after they're paralyzed in these patients, you'll notice the pressure drops all the way down, and you'll maybe have like a normal plateau pressure, which is less than 30, maybe even like 15, 20, right? And the peak pressure of 60 dumping all the way down to a normal plateau pressure of 20, you know that all of that pressure that it took was not due to the compliance of the lung. You know that it was due all because of the airway resistance. Versus normal air resistance, you won't have such high peak pressures and you'll have the same plateau pressure. Versus if there was air trapping, if there was a ton of extra air that the patient wasn't able to exhale, you're auto peeping, dynamic hyperinflation, basically all the same term. Then you'll see when you do a plateau pressure that the plateau pressure will also be super high. We'll talk about that in a little bit more as well. So getting air in is hard for asthmatics, but the biggest challenge you're going to have is how to get that air out. How do you even know if on the ventilator, they're not telling you anything? How do you know that they're not getting their air out? Well, you look at the flow time wave. There's a few ways. One of the ways is this way. So remember, this is volume control because it's a square flow waveform. So you inspire in, and normally as you expire, the flow should reach back down to zero. As you guys, as all of us breathe, at the end, after you exhale, your flow should completely stop. But these patients have a really hard time getting their air out. So these patients take a lot longer to expire than you or I. But if the ventilator causes the patient to breathe in, or if the patient themselves are feeling air hungry and they breathe in before they're able to fully exhale, if there's pressure, if there's flow, there must be some volume. So they're going to start to air trap. Sometimes though, they're so constricted that it's really hard to tell. They're like already so constricted, it's hard to tell whether this is actually reaching zero or not. So another trick that you can do is the area under the curve, the flow time waveform is actually the volume. If you look at the area under the curve of the inspiratory limb, and if you look at the area under the curve under the expiratory limb, would you guys agree with me that the volume under this curve is greater than the volume under this curve? The patient is auto-peeping. And lastly, what you can also look at, least reliable, I would say, is the volume time waveform. If the volume time waveform is not reaching all the way to the bottom as well, and if your exhale tidal volume that's being measured by the ventilator is less than the tidal volume that you're giving them, then you kind of know that they're not exhaling everything that they need to exhale out. But there's a caveat to this. Sometimes there's a leakage, right? Sometimes there's a little leak in the circuit. For example, if the balloon's not inflated enough, then a little air passes around the circuit. That can also give you this kind of finding on the volume time waveform. So be careful with that. I would go with more of the flow time waveform to know if the patient's auto-peeping or not. And lastly, this is also sometimes reliable, but it's most reliable when your patient is paralyzed, right? So, which is why I'm telling you guys this now. So just like there's an end inspiratory hold, there's an end expiratory hold. So as the patient gets their breath, this is the pressure time waveform, the one at the top. So at end exhalation, it comes down to their set peak, but once you have them stop and allow the pressures to equilibrate between the ventilator and the patient, you'll sometimes, in patients who are auto-peeping, air trapping, you'll see the pressure waveform kind of come back all the way up here. So that's the intrinsic peep or auto peep or peep that's generated by the volume that they couldn't exhale, right? It's all the same thing, dynamic hyperinflation. That's the peep, that's the auto peep that the patients are experiencing. When this number reaches above 20, it's pretty bad. You may want to consider detaching the ventilator and giving them what we call the asthmatic hug. It's kind of just press, mechanically, you press down and allow that air to come out. So why is this bad? Well, it's bad because one, it's causing hyperinflation of the good lungs that you want to use to participate in gas exchange. It's bad because remember the cardiopulmonary interactions that PEEP does, right? It reduces, you're already, by using positive pressure, you're already reducing venous return, which at the end of it all reduces cardiac output, right? But if your PEEP goes up to like 20, 25, 30, then all of that blood that wants to come back cannot come back. And these patients will become hemodynamically unstable as well. So to summarize obstructive lung strategy, low respiratory rate, 10 to 12 or less. There's this idea of the I to E ratio. To make the numbers easy, let's say in 1 minute, well, not just to make the numbers easy, in 1 minute, there's 60 seconds. So in 60 seconds, let's say you're breathing 20 times a minute, okay? So each breath, you'll have 3 seconds to take each breath, right? Let's say, for example, your inspiratory time, the amount of time it takes to inspire is 1 second. So in that 3-second breath, you're allowing yourself to get 2 seconds to expire. So 1 to 2 ratio. That's not nearly enough for asthmatics. So you have to reduce that respiratory rate down to 10 to 12 or even less if you can do it in order to allow them to exhale, especially in severe asthmatics, to an IDE ratio of like 1 to 4, 1 to 5, if you can manage it. Tidal volumes of 6 to 8 cc's per kg. Okay, so James, if your respiratory rate is low, we should at least raise the tidal volume. The PCO2 is like 80. What are we going to do? Well, look at this curve. If you give them too much of a tidal volume, that also, if you give them more, you're going to take more time to get this out, right? So that's a huge problem too. So don't target such big tidal volumes. And there's just the same as severe lung injury strategy in ARDS, there's also permissive hypercapnia in asthmatics, right? Don't forget, remember, like your ventilator is not fixing the asthmatic. Your bronchodilators, your steroids, time, that's what's fixing the asthmatic, not your ventilator. What you're using the ventilator is as a crutch. You're okay with their PCO2 being a little high in order to allow them time for your therapeutics to work. So that's ventilation. Oxygenation, don't over-oxygenate. So what happens when you over-oxygenate? So there's a little funny thing that your pulmonary vasculature does. If you give oxygen to a lung unit, the pulmonary capillaries will vasodilate. So what happens to all the lung units that were not participating in gas exchange because they were so hyperinflated already, and you give a ton of oxygen to that lung unit? Now there's going to be more blood that goes to that lung unit. And what happens? Not just your oxygenation, but your ventilation will also be impaired because you're not performing gas exchange there. This is controversial. Like, what should we do for PEEP? They say 0 to 5. Some people say that if you have a ton of auto PEEP, if you have a ton of dynamic hyperinflation and your lungs are super, super inflated, your small airways tend to collapse. And whatever's stuck behind the small airways that collapsed, you can't blow the air out. So you may have to match the amount of auto PEEP that you have to around 60 to 80% in order to stent those little small airways open so that you can exhale whatever's behind those small airways. This is what people say. In terms of preventing harm, please monitor for auto PEEP, aka again, reiterating the same thing over and over again. And you can use an expiratory hold for that. Use your inspiratory hold to look for the compliance issues, right? If their plateau pressure is all the way above 40 in an asthmatic who shouldn't have any lung parenchymal disease, then you know you're really, really, really hyperinflated. And so, I'm almost done. So the understanding resistance and compliance is not just helpful in ARDS, and it's not just helpful in asthmatics. It's helpful in general, just sort of when the sicky nurse comes to you and you're alone at night as a PGY2, and you're like, oh my God, what do I do? Doc, the pressure is high. The pressure is high. Come right now. You know, in red letters, you know how they send those messages. Oh, act right now, act right now. And you're like, oh God, okay, I don't know what to do. And then you go over to your patient and their pressures really are high. It's at like 50 when they were at like 20 just a few minutes ago. And you can come up with a differential by using your end inspiratory hold, by using your plateau pressure, right? So remember, the plateau pressure is the marker of compliance. If your peak pressure was at 50 and your plateau pressure is now at 20, which is normal, or 15, which is normal, then you know all of that stuff was due to high resistance. And listen to their chest, right? If they're wheezing, okay, sure, give the bronchodilators. But if they're not, then maybe it's something wrong with the circuit. Kink in the ET tube because they're biting down on it. Maybe it's a mucus plug. Maybe there's a bunch of secretions and the RT just hasn't been there. Like Jacob's lecture about the mucus plug. Maybe they just haven't been around to suction them in a while. Or bronchospasm, right? Like asthma. But if you do your plateau pressure and it's high, your peak pressure is 50 and your plateau pressure is 40, then it's a compliance issue, right? Then you know that it's in the parenchyma itself. So maybe they develop pulmonary edema. Maybe the tubing moved into the right main stem, and now you're giving 6 to 8 cc's per kg, not into 2 lungs, but you're giving it to 1 lung, causing hyperinflation of that 1 lung. Maybe you have a sicky patient that just went to the OR, and now they're back, and now they're developing abdominal compartment syndrome, and it's preventing the diaphragm from contracting, and it's requiring the ventilator to use tons of pressure to get that diaphragm to flatten. So obviously, it's not going to work if your patient's in any respiratory distress, but if your patient's still calm and they just have high peak pressures, it's something that can be very useful. And then for everybody else, the general ventilator strategy. So for ventilation, 12 to 16 breaths per minute. There's a caveat there. If your patient's acidotic and you need their minute ventilation to be a little higher, you can always increase your respiratory rate. Tidal volumes of 6 to 8 cc's per kg, like we mentioned. Oxygenation, we're always going to start at 100% FiO2 after intubation, right? But wean that down ASAP to target around an oxygenation of SpO2 of like 95%. And a PEEP of at least 5 to overcome the resistance of the tubing. And remember, you can increase based on their pathology. If you're an LV failure, it can help to augment cardiac output. And if you're hypoxic, remember PEEP. And in terms of preventing harm, this is maybe the fourth time or the fifth time. Make sure to titrate that oxygen down. Monitor your patient's plateau pressure and ensure that you order post-intubation sedation. So in summary, it's a lot to summarize with tidal volume and respiratory rate for ventilation, FiO2 and PEEP for oxygenation. Remember the concepts of compliance and resistance. There's two general strategies for your sickest patients, your lung protective injury strategy and your obstructive strategy, along with your general ventilator strategy. And these are my references, and that's it. Thank you.